Thank you all for coming back and listening to the podcast this week. And this week I have a very special guest, my very first special guest, and that is Teresa Foley, Specialist Paediatric OT. Teresa will speak more about her experience in a moment, but I wanted to, I suppose, let you know what the podcast will focus on this week, and that's on Arfid. So I'm going to attempt to say this in my Mayo accent, what Arfid stands for, and that's Avoidant Restrictive Food Intake Disorder. And I suppose my interest in this is more than anything as a parent, because I have two sons. My eldest son, Connor, who has Arfid, but especially as an infant, when he had Arfid, I didn't have the knowledge base that I have now. I didn't know about absolutely fabulous Teresa. I didn't have a Teresa Foley in my life at that time, and I really struggled, and to the point that my gorgeous Connor eventually stopped to eat at all. Now, Teresa will, I suppose, speak more about Arfid in a moment from the clinical lens, but as a parent, that really I suppose terrified me really. And I suppose I've been on social media for the last decade. I see lots of great information posts going out there, but specifically on Arfid, I'm always quite terrified about the information that's available. And I always just say to myself, I just wonder what's that clinical, I suppose, background or experience of that individual sharing that content? Because just like everybody else, I'm a parent on social media, and just like everybody else, I might be taking up that information going, this is great, I'm going to try that with my son. But having had, I suppose, that experience of almost well over a decade ago with my gorgeous Connor, who's a teenager now, we ended up in a hospital with Connor where he could not eat at all and was eventually put on a very specialist supplement, I suppose, drink, because he wouldn't intake any food. And now I find myself once more on our family journey back on the road with Arfid, but with my youngest son, Max, who really has restricted his food intake to, I suppose, a handful, less than 5 at this point in time, of food that he will tolerate or can accept. And again, I suppose for me, I continue to see these like really informative posts about Arfid on social media, but I always go back to, but what is the clinical experience? What is the person's specialist knowledge base? Because as a parent and as a professional, I'll tell you, as a parent, if you're listening, or as an autistic person, always check in and just wonder, where's that knowledge base coming from? Is it just a quick post somebody put together, or is that a specialist person that has worked in this area for a number of years and that has seen countless individuals and supports them through their programming to, I suppose, come out the other side and be able to eat, I suppose, a more varied diet, or I suppose continue to be able to eat. So again, I'll stop talking about Arfid. I'm going to now introduce the incredible Teresa Foley, who's been, and I cannot tell you if you're listening, such a support to me and my beautiful Max. If it wasn't for Teresa, I don't know where I'd be. And I know Teresa might mention, I hope you will mention, your magical Mealtimes program. I again enrolled in that myself. It's not a sponsored post or anything. I paid for it myself. I did the course. I thought it was absolutely fabulous, and I tell everyone all about it. But I'll let you maybe introduce yourself a bit more, and I'll stop talking with my very heavy Mayo accent. So Teresa, thank you so much for being here today.
Thanks so much, Amanda. And it's such a privilege to be here talking on your amazing podcast. And can I just say, on behalf of many people, thank you so much for everything you do for the autistic community and all of us working in this field. You are just an incredible resource. So thank you so much.
You're very kind. You're too kind.
I suppose my passion for working in this area and my interest and my experience spans back several years. I've always worked as a children's occupational therapist for my entire career now, for the past 16 years, both in Ireland and Australia. And I was very fortunate to work in Dublin at the Central Remedial Clinic in Clontarf for over 8 years there. And for a large part of my time working there, I worked at the specialist feeding service. So initially I would have worked with children who had physical disabilities actually, and things like cerebral palsy and dysphagia, swallowing difficulties. And we had a very specialist feeding multidisciplinary team there, myself, pediatricians, speech and language therapists, dietitians, psychologists, social workers. We were blessed. We had a gold standard multidisciplinary team there. And we were the national kind of specialist service for children initially with physical disability and feeding difficulties. And then a few years ago, I was part of a group of professionals who established the first clinic in Ireland for children with what we deemed complex feeding challenges. And would you believe this was actually the first time that I ever heard of the term Arfid? Now, on reflection, I had been working with children for several years who I now know had Arfid, but they wouldn't have had that diagnosis. And so Arfid is actually a very new diagnosis, and it was only actually recognised in the literature for the first time in 2013. So it's still very, very new, both in terms of research, in terms of information, and in terms of trickling down into kind of clinical practice and everyday parlance, if you like. It's very new. But when I started working with that client group as part of the complex feeding service in Dublin, I just felt like I had landed in terms of my OT career. There was just something about working with these children and their families. It just resonated so deeply with me. And as a clinician, I suppose I felt I got to bring all the best parts of my career as an occupational therapist together. And I mean, For me, I love to eat. So, for me as an occupational therapist, I see eating as such a core occupation. Like, I do it several times a day and I look forward to eating and I love to go out to eat. And I just thought for these poor children and teenagers who couldn't eat and for whom eating was such an anxious and a traumatic experience in some situations, I just couldn't believe the implications it had for the child, for their parents, for the entire family. And it just really grabbed me in terms of my own interest. So I worked with that team for a number of years. Then, after my third maternity leave, I actually set up my own specialist service for children with complex feeding challenges called the Feeding Therapist. So I suppose I do both one-to-one consultations with parents and families there. I see children at my clinic with complex feeding challenges, and also earlier this year, I, after a long time, developed an online course for parents and carers of children with Arfid, and that's called Magical Mealtimes. And that was a course that I designed myself, built from scratch, because there was really nothing like that out there, I believed, for parents to access information that was both up to date, accurate in terms of the information it provided, and research based. So as a clinician, I have spent years working in this area and I'm still doing postgraduate training in this area to be able to keep up to date with the most current practices, the most current information. Like, as you know, as somebody who is autistic and somebody who's working in this area, our practices and the way we're working in neuroaffirmative ways, that's evolved hugely in the last few years.
And continues to evolve.
Absolutely, and I hope it will. And some of the ways that we would have worked with autistic children in particular when I qualified 16 years ago, we wouldn't dream of doing things like that now. So it's a very rapidly changing space, and so I feel like I have a responsibility to keep on top of that for myself and also for the families I work with. And as you can tell, it's something I feel very passionately about, and I'm on a mission to spread both awareness and understanding of this condition and of complex feeding challenges overall.
Well, first of all, I can say as a parent, and again, as I say, I can show the receipt. I did pay for your course myself. That's before I even really got to know you. I just saw the course, and
Yeah, great.
following your social media, I'd been seeing all the information you've been providing to help all of the community. I thought, God, I'm going to do that. As anyone that knows me that listens to the podcast, I do like to research and I do like to learn as much as I can. I thought for my gorgeous Max, I'm going to get down and learn all about this from. I suppose when I learned about it initially, as you say, 10, 11, 12 years ago, we didn't have the knowledge base that we have now on Arfid. And I was only starting out. And again, I was a parent altogether starting out on the autism journey with my beautiful Connor. So I knew back then, whatever knowledge base I did have, it wasn't as vast as it is now. But I still found I learned so much from your program, because I often think, God, is there anything new to learn? As you say, there's always something new to learn. But what I really liked about your program is that it's sectional. You can just take it a step at a time, learn the piece that you need to take with you for now. But it's also very practical, really practical strategies, and excellent. Again, I do love a visual support, excellent visual, myself, excellent visual resource. I was like, oh, I really like the way you designed that. But I just thought very accessible. The families can download the resources, watch back, which are really like watch back for reassurance, and then move off again and keep trying to support their children. So I thought it was hands down excellent. And again, can I ask you, I suppose you've already kind of given all of your experience, but I suppose if you've heard what I said at the start, I always say to, and even I was on calls with families this week myself, working with them directly, and I would always say to them that whoever they go to, a clinician, like really check for that, I suppose, clinical experience. And from your perspective, say if you were supporting a family and they were saying, what's your experience clinically? Why do you think it's important that families, say they're listening to the podcast, or parents or professionals, why it's important that they ensure, and I would say across all contexts, but in this specific context on Arfid, why is it so important that they make sure that the person, say if they're going to watch a webinar, if they're going to say download a social media post, say, oh, I'll use that. Why is it important that they make sure that the person they go to not only has all of that years long, qualifications, but also that years long clinical experience?
I suppose, to put it in very simple terms, I feel like our children only deserve the very best of any services. Whether it's occupational therapy, speech and that, whatever it is, these little children deserve only the very best that they can avail of. And so in Ireland, if you are accessing the services of a health professional, like whether it's an OT, dietitian, speech and language therapist, I always firstly encourage parents to check if that person is on the CORU register. So the CORU register is our national register for health professionals in Ireland. Interestingly, the only profession that I'm aware of who are not registered yet as part of CORU are psychologists.
Okay.
But aside from that, you can go onto the Cora registry today and you can check for my name and check that I'm there. And that means that I am fully licensed and registered to practice in Ireland, and that I have all my training up to date, and I am what I claim to be. Then in terms of feeding specifically, I suppose feeding is a very sensitive occupation. It's, in terms of parenting, it's a co-occupation, and particularly for young children, if you think about it, a lot of feeding can be imposed on a child. When you think about it, like when you're
Spoon
feeding,
feeding.
exactly, or even a baby before that, like you can,
The bottle, yeah.
you're putting the bottle in their mouth. So a lot of feeding is being done to a child, if that makes sense. And definitely over the years, I have heard that quote always comes back to me. When we know better, we can do better. And I sadly have heard some very heartbreaking stories from parents who will say to me, almost whispering, like, I did try and force feed my child, or the doctor told me to let them go hungry, and I thought I was doing the right thing, and so I did that. And sadly, because when we're dealing with Arfid and other feeding challenges, if we maybe don't follow the best advice, or maybe the person who's giving the advice doesn't have all the information or training available to them, sadly, the consequences can be fatal for these children, because we'll,
Literally.
we'll, we'll talk about it a little bit more in a minute, when I expand on ARFID as a diagnosis itself. But honestly, if a child with ARFID is left to not eat, or maybe is forced to eat things they don't want to, they could potentially starve. So they could go on to become malnourished, severely unwell, as you sadly know
Yeah.
about. The consequences can be fatal. And or if a child is being, fed under circumstances that they do not feel safe in, it can be hugely traumatic for that child and for the parents.
And have
So
long term impact.
absolutely, it can change the trajectory of the way that they feel comfortable in eating for a long, long, long time. So, obviously, every aspect of healthcare is, we need to have the highest standards. But I think it's particularly important in this area, both to have the training and qualifications, but also I think to have that clinical experience is so
Yeah.
important, because Amanda, like, unless you've walked that road of that desperate feeling of thinking my child could actually starve here,
Mm-hmm.
and I've heard those devastating stories from so many families. It's very hard to grasp how
I know,
difficult.
I'll often pop up a post and I get lovely messages from parents, and they'll just be saying, "Well, I'm in a similar situation, but I was trying to, like, sneak in some food there, and like my heart goes out to them, because I know that desperation. I know, because when I watch Max, like, Max is well able at this point to feed himself, but I will
Yeah,
actually support him to eat his dinner, and this might sound like such a silly thing to say, but every spoon, like, this is literally the only dinner he will eat, and again, I layer it up with like extra butter and everything just to get him
yeah, of
a
course.
few calories. He'll eat
Yeah,
mashed potatoes and only, this is not a sponsored ad for bachelors, but only bachelors beans. And I
yeah,
swear to God, I'm sure if anyone was to look in the window, which I don't think anyone would bother, I probably look absolutely nuts. I'm nearly crying, being like, okay, that's 10 spoons. Okay, that's at least,
I
okay, that's
know.
not bad. And you're counting it down your mind, but you're trying to co-regulate, be very relaxed. So very
Yeah,
good, well done. And I let him do whatever, he's have his iPad, whatever, long as
yeah,
he keeps eating. And then when he says he's done, I respect it. And I go, okay,
yeah,
well done.
amazing.
Thanks, Max. And I let him
Yeah,
off. So I'm going to move on, because I put out a question box on my social media with questions, and we have a number of questions. I hope we get to them all. If we don't, I'm sure we could always catch up again another time. But I
exactly. Yeah.
suppose I frame them under different headings. So the first one is under the heading of background on ARFID. And this is the first question that came in. And it says, can you explain what ARFID is and how it differs from other eating disorders? What are some common misconceptions about ARFID? So maybe that's two questions.
Yeah, absolutely. So, ARFID, avoidant restrictive food intake disorder, is technically an eating disorder. It's listed in the DSM-5, which is the diagnostic manual that we use. It is technically an eating disorder, similar to things like anorexia nervosa, bulimia nervosa. However, the really interesting thing about ARFID is that it is the only eating disorder where the individual who has that eating disorder does not restrict their food intake for the purpose of losing weight. So that's the major differentiation, because I know for some parents, when they hear, oh, my child has an eating disorder, it can take them by surprise. And even if they hear that it's a mental health condition, it can often be a little bit uncomfortable or tricky for parents to hear that. So I always say, yeah, but just remind yourself that they're not doing this purposely for the reason of losing weight. It's for alternative reasons. And so there's 4 different subtypes. So the first one is sensory sensitivity to food. So that can be anything to do with the appearance of food, the smell of food, the texture, any of the sensory properties, or anything to do with the sensory experience of eating. The second subtype is kind of fear based avoidance of eating. So that can be things like a fear of aversive consequences of eating. So you'll sometimes see that maybe in children or adolescents who've had a previous traumatic, they might have had like a near choking event with a particular food, or they might have eaten something and then become very sick, vomited profusely afterwards. And so then they have an associated fear response with that particular food. And the last one is lack of interest in eating. So some people do not have the same hunger cues or the same awareness or the same information coming from their body or the same interest in eating as I do. And so those people just don't feel the need to eat in the way that other people do. And really interestingly, then now we know that there's actually a fourth subtype, which is a combined subtype. So I'm pretty sure the most common subtype is a combination of sensory sensitivity combined with the lack of interest in eating. And the least common subtype is the fear of aversive consequences of eating.
So interesting.
Yeah, it's fascinating.
And does one stand out to you more than the other as, say, what you're seeing daily, or is it kind of a mix of them all?
I would find the sensory sensitivity, particularly in relation to the autistic population, it's for me, it seems to be the most prevalent one. But I will say, as I said, it's a very new diagnosis. The research base is still evolving all the time. There's a couple of kind of seminal research papers now. And so I'm watching those carefully. Maybe things will change. The amount of people who every year are being diagnosed or identified as having Arfid is growing. And so that's a good thing because it will allow us then to get more information on the lived experience and what the different kind of presentations are of this condition. And really interestingly, like now there's a lot of adults been diagnosed with Arfid, which a few years ago was only young children. So we're learning more about it all the time.
Yeah, and what I find, I suppose, really interesting as well is even I follow a number, I can't think of their names now, but I'll put it maybe in the bio of this podcast,
Hmm.
a number of individuals, I think we chatted about it before, that are like really providing just from now, they're not obviously offering professional services, but they're giving that lived experience of how they manage their day to day, which I think is really important. But
Mm.
again, following through with, if I'm going for support, I go to obviously the clinician for that, because as
Yeah,
you say, it not to be morbid, but it really can lead to like a very unfortunate end for any individual that has ARFID. So
great.
it's really important. Okay,
Yeah.
I'll go to the next one. The next question is, why do you think ARFID is more prevalent in the autistic community?
So there's a couple of different reasons, and this is this is my take on it from working with these people. I definitely feel like there are first of all, there's an overlap. There is a genetic overlap. So there's similar shared genes between ARFID and autism. And I suppose I will say as well before I talk about this a little bit more, I definitely feel so. I think the statistic is up to approximately 90% of children with autism will have some difficulties with eating.
Okay.
So that's a massive statistic when you think about it.
I can think in
Um,
my own household, even though we're talking about ARFID, each of the boys has a very particular way of eating, and probably even myself, I wouldn't even tell you I had a scone earlier, but I wouldn't eat anything till I had a beige scone. So, like, despite, as I often say, I only eat a certain amount of things every day, but they're generally always just a beige carb. And I don't really have a strong sense of hunger. I just kind of, like this
wow,
time of the day, I feel like I'm about to faint. And then if Haley was home with me, she'd say, "Did you eat, ma'am?" And I'd be like, "Oh, no, I
wow,
didn't." And then I reach for the
wow.
quickest thing, which is a carb, which is, I could show you now.
Yeah,
Maybe I will, just to prove the point.
yeah.
This is my beige scone that I'll be finishing
Okay.
after the podcast. So
Wow. Okay. That's fascinating to hear about the kind of lack of hunger cues or, that they
I just would never
don't
have
experience
do you know what I'd
those.
love? A lovely something. And do you know what I thought was really interesting was during the pandemic, they were talking
Yeah.
about, you might have no sense of smell and no taste. And I was like,
Yeah.
I must have had COVID since I've never really had a taste for any. Maybe it's no, maybe it's
Wow.
me. Maybe I'm the super spreader because I have no taste for food because everything tastes like nothing. So it's not like
Wow.
I'd not have a thing for like, oh, I'm going to have this thing. And whereas I'm very
Right.
sensitive to smell, but the taste of food always tastes like nothing. There's nothing that would make me go, oh,
Wow.
that's so fascinating. I'll have that.
Yeah. Or you wouldn't have that kind of craving for something or
No,
a longing
it's
for
more
something.
that I'd be starving to the point I'm starving. Then I'm like, I just need to eat something now. And then it's
And then
nearly too late.
And what's interesting, what parents often say to me is, then the child or the young person will just want either something sugary or something kind of carb based. And I sometimes say to parents, but if you haven't eaten for hours and then you just need an energy boost, you can understand why the child might want something sugary, because they need a boost of energy and they need that kind of pick me up. So, you can understand why all of a sudden then you feel that horrible feeling of low blood sugars, low
You feel
energy.
on edge.
It's a horrible feeling. So I suppose when you think about that statistic of up to 90% of autistic people experiencing some difficulties or challenges or differences, I guess is the best way to describe it, feeding differences. That's a really big statistic. And so, there's definitely, in my experience, autistic children will have a preference for a sameness around eating. And as you've described so eloquently there, that can be maybe sameness in terms of food itself, or it can be the way that food is served. I have lots of autistic kids who come to me who only maybe like their toast in triangles, and if you gave it to them in a whole piece, that would be not to their preference whatsoever. But interestingly, and I call that, now I hope this is not disrespectful, by the way, this is my own term for that. I kind of call it autistic eating.
I would call it that as well. That's what I would
Would you?
call it.
Okay,
Yeah,
good.
would you?
And like I met a mum at the weekend and I was telling her what I do, and she said, "Oh, my daughter is 16, she's autistic," and she said something like, so every day she has the same dinner, and then on Fridays she has a pizza because it's Friday and you eat pizza on Friday. And she was like, and she's delighted. And then the other 6 days a week she eats the same dinner. And she said to me, like, she doesn't have Arfid. And I was like, no, she absolutely doesn't have Arfid, but she has a strong preference for sameness and routine in how she eats. So that's what I would see. And I definitely think then, there's an overlap in autism with things like sensory processing differences. As you described there, the differences maybe with interoception, responding to hunger cues. I think there's a lot of overlap, but the evidence would say that the autistic piece can exacerbate the Arfid piece. Does that make sense? So,
Yeah, absolutely.
an individual who was not autistic but had Arfid might experience, they might have a preference for eating certain food in a certain way, but the autistic individual with Arfid might be very reliant on branding of food. Or, as you said, they might only be able to tolerate their toast cut into a certain way because that might give them more
And
comfort.
this might sound like maybe not strange, but the brand, I don't know if it's in Dublin, it's O'Hara's bread, again, not sponsored, but O'Hara's bread is Foxford, which is only a few towns away from me, and that's where the bakery actually is. And for Max, at one point, I don't think I could. I always buy the O'Hara's brand for whatever reason. Maybe didn't have it in the local store. And on Sunday evening, I panic if I haven't got the bread, because everyone in the area is buying like bread for lunches. And if I haven't got the O'Hara's bread, then I'm on the hunt, because that's the only thing that he will definitely eat as toast. And one particular day, and again, he wouldn't regularly be seeing the packaging, but I gave him some other brand, and he would not eat for that Sunday evening. He would not eat, and again, that means that's a missed opportunity to get him to eat, or to have him to eat, or support him to eat. So it really is so. And I often think that's probably, think from an autistic lens, that's preference for that sameness, even in visual processing, that if you break the pattern, well, that's not what I'm used to, you've broken the pattern, therefore I will not have it. And again, I remember texting Max's dad and be like, could you get that in, go, he was somewhere, I said, could you see on the way, I think he was in Galway, on the way down from Galway, could you pull in somewhere and get an O'Hara's loaf, so at least he'll eat before he goes to school in the morning. Because then I had broken his trust in this was what he was going to have. And then he checked in the morning when I was going to make the toast, he was like, no toast, no. And then I opened the press, I was like, oh, Max's bread. And he was like, 3 toasts. It meant 3 slices. I was like, 3 toast. But I could see, as you say, through that autistic lens, it's not just the specific difference for eating, but there's the autistic lens on it as well as to the why.
Absolutely. And like, I remember reading something before, it was a teenager who had Arfid, and, they were telling the story or making the analogy that, if you had presented Max there with, say, O'Hara's bread, and then you put Brennan's bread beside them, and like, to me anyways, in your typical person, I probably wouldn't be able to tell the difference. But this teenager with Arfid was saying, you may as well be putting peas and carrots out, because the difference to somebody who has that lens is night and day. To them, there is no similarity.
Yeah, no, I totally agree. Okay, I'll go on to the next question, because I'm realizing, look at the time, and we've only got to question 4. Okay, question 4. Can sensory processing differences contribute to Arfid, and if so, how?
Absolutely. So I could do a whole podcast on this topic on its own,
Maybe
but
we
to
will.
try and keep it as brief as I can. Eating is the most sensory based experience that we as humans engage in. So when you think about it, like food is eating, and food and enjoying food is so much more than literally just putting food in your mouth. So we have eight senses in our body that we engage in, and food, when you think about it, there's a lot of different sensory elements to eating and to enjoying food. So think about it, there's the touch of food when you put it in your hand. Then when you put food in your mouth, you have to be able to tolerate the different
Mhm.
textures of food. So a lot of individuals who have Arfid will have a strong preference for beige, bland, crunchy, dry food, but not all, but that is a large kind of preference. Think about the smell of food. Think about even the sound of food being cooked. If you go into the kitchen and maybe there's a stir fry being cooked or something like that, it can be very loud. Even things like when you bite down on a cracker, sometimes like the crunch. To me, I wouldn't experience that as being very loud, but to some children or some individuals with ARFID, that can be too much for their sensory system to tolerate. So, and also even things like having to sit up in the chair, having to use our body position, being able to tolerate and control our, our core, our postural stability. There's several things involved. I spoke already about interoception, so our body's ability to recognize and respond to hunger cues. And you described so well, if we're not able to pick up on those hunger cues in that moment, how then we don't eat until we're almost in like a hypoglycemic state and nearly
Literally.
collapsing with hunger. Um, and then some parents will describe to me like their children having what they call a hunger meltdown because they've gone past the point of being hungry and they're nearly, you know,
Starving.
yeah. So it's a hugely complex experience, and I suppose, you could spend all day reading about sensory processing and the impact it has on food. And to be fair, in the Magical Mealtimes course, like I have dedicated an entire
You have.
module to sensory processing and sensory differences and sensory preferences and how that relates to eating. But I suppose if I was going to put it in a nutshell for people listening today, I would encourage parents to think about the impact that it has on function. Because
Mm.
actually, if I were to do a sensory questionnaire or a sensory profile with anybody I met, my sensory preferences would be different to yours and yours would be different to Max's. And that's fine. But to me, it's only when the sensory preferences are so great that they maybe stop you being able to eat at the table with everybody else because maybe the smell and the appearance of other people's food is too much for your sensory system to tolerate. And so you might become overwhelmed by the smell of that food. Or, as a lot of children do that I meet, they will actually gag in response to the smell
Mm.
of other people's food. So, if you're somebody who only likes to eat oven chips, say for your dinner, or maybe chicken goujons or something, but if you've quite a strong preference for bland food that's not very strong smelling, and then you're sitting beside having a spag bol, the smell of that or the appearance of that, it might just be too much for you to tolerate. And so sometimes these children cannot eat at the table with the rest of their family, or they go to school maybe where there's could be 5 or 6 different lunches at the table, and again it's too much for them to cope with, and they have to leave the table or maybe not even be able to eat at all at
I was just
school.
going to say, yeah, I could imagine not even eat because this is not exactly the same. But I know for myself, if I was going into a restaurant and whatever it is about fish, and it's always been that way for me, if I can smell any fish, I'll just turn around and leave because
Wow.
I would just feel so nauseous the whole time. And I don't know why, but I
Yeah.
would literally just exit as soon as I can because it would just make me feel.
Okay.
But do you know what's actually maybe a bit strange about that is that there's times in my life where I like, do you know that salmon in a tin?
Yes.
It's very stinky actually, just because I'm very sensitive to smell. But occasionally I'll have the urge to have now. But what I'll do though is I might eat that for days on end, and then I come out of that cycle, and then I never want to see fish again. But I might have
Yeah.
that on toast randomly. It could happen once. It probably does happen about maybe once a year. And then if I
Okay.
smell fish anywhere in the meantime, I nearly want to run out of the place if I smell it.
And have you heard of the term like food jagging before?
No, what? Never. What is that?
Okay. So food jagging is something that you see in Arfid quite a lot.
Oh, interesting.
So, and again, thinking about the autistic lens versus the Arfid lens, like there's definitely commonalities in both. So food jagging is where an individual who maybe has
I feel
limited
like I'm going
food
to learn
preference
something about
to start
myself now.
with, they will maybe, because a certain food can be they deemed like a safe food or preferred food is the term I use. So for example, like if you like jam on toast and you're like, okay, I know that jam and toast is something safe for my body. It feels good. It's, I enjoy the taste of it, but also I know that it won't make me feel dysregulated from a sensory perspective, and my sensory system can cope with that food. So you eat that every day because you know you can cope with that and you like it. And so you might eat it on repeat. And sometimes you might even eat it twice a day or sometimes
Three
three times
times.
a day. Yeah, because that is a safe food for you. But then sometimes what can happen is, and what often happens is, these individuals will all of a sudden go, oh my God, they burn out on that food. And so then they, as you literally described there, Amanda, they just go, oh my God, I never want to see it again.
Mm.
I have overdone
Yeah,
it
yeah.
on
When I
that
eat it,
food.
it's like an intense cycle of I'm only going. I mean,
Yeah,
I wouldn't eat like anything else for breakfast, anything else for dinner, or anything else. I would just eat that same thing for like could be about a week at a time or 2 weeks, and then after
yeah,
that, I never. But I would do that with other foods as well. Like I know I
yeah.
was saying this to Haley the other day. Manhattan popcorn. It comes in the red
Yes.
bag. I
Yeah,
would go
yeah.
not so much now, but I used to go through cycles when the kids were smaller where I'd only eat that for breakfast, lunch, and dinner. And
Wow.
I don't know. I know that's a lot of fiber, but also, but I had no preference. Food doesn't taste like anything to me. But it's
Yeah,
more to do with smell for me if I have an aversion. But
okay.
I would just like very random to eat a lot of popcorn. But I might go through weeks of only eating that, and then I'd be like, I'm never eating that ever again. And I don't actually know when I last ate that particular brand of popcorn. Probably a few
Wow,
years ago.
okay. Yeah. And like, to me, the thoughts of eating popcorn 3 times a day would be too much for
Extreme.
my system to handle. But I mean, I hear about those things all the time, and see, that is okay if that's what your body needs in that moment. But then there's a couple of risks to that, because the story that I hear from parents all the time is, number one, that the child will eat it on repeat and then they will burn out on it and drop that food. And so then the child doesn't necessarily replace that.
Yeah, I
So
was going
they
to say.
decided, okay, I never want to see Manhattan popcorn again. It's not like they go, but I will start eating cupcakes. That doesn't happen. So usually what happens is the child will just drop that food. And if you only eat 6 foods to start off with,
Now you
then
five.
you're down a whole food. So that has a big impact on your overall food preferences and your nutrition. And so one thing that I, as a feeding therapist, one thing that I do work with families is how to prevent food jagging,
Okay.
because if a child drops a food, then not number one, they have dropped a food, but also, like, there's times that, say, companies stop making food of particular brands. So this happens all the time, that they will either maybe just discontinue a particular line of food, or they might change the packaging, and so that packaging then is not recognizable to the child, and so they stop eating it. So it's fine for a child to keep eating the same food, but if circumstances beyond your control mean that food is not accessible, or if the child no longer wants to eat that, then what we want to do in feeding therapy is just to help them gradually expand their choices very, very slowly if we can, and if the child is able to. But that is a particular situation where you very much need the help of an experienced feeding therapist,
Yeah.
because that has to be done in a very specific and a very neuroaffirmative way.
That's really interesting. I'm even thinking of
Yeah.
Max. Like he used to at least eat. There was I think it's again. This sounds like I'm having sponsored recommendations, but he used to eat a yogurt by a brand. I think it's Glenisk, and it was banana
Yes.
yogurt,
Yeah.
organic banana, and he won't eat
Yeah.
it anymore. And earlier I saw the brand. I was rushing around at the store earlier. I saw it in Tesco, and I was like, would I just buy it? And I was like, no. He's happy enough at the moment. I'm going to try that now another day. But I remember I kind of get. This sounds really silly to say, but I feel like grief when I see like brands that he won't eat the food anymore. And I'm just like,
Wow.
maybe again, maybe again. But I know that he will again one day. But it's just to keep him on track with continuing to eat for now, for me, I suppose.
Yeah, but that, I like, to hear you say that it's like grief to think back to the foods that you used to eat, like that, just so it describes so well the emotional impact of this condition, not
Mm.
just on the child but on the whole family. And as parents, like I say this all the time, when you're handed your new baby, like when your new baby is born and they're given to you, the first thing you do is feed them. And then if you can't feed your child in the way that you would like to, or the way you hoped you would be able to feed them, it's it's devastating for
It
parents.
is. And also I think from my perspective as a parent, I just feel like such a failure because but I suppose I have the educated lens now on it now
Yeah.
as a professional. Then I know it's not actually my fault. I'm doing everything right. I've done your course. I'm learning as I go. I've bought all the book recommendations that were on the course.
Yeah.
Would you believe it? I bought them all. I've been
Oh,
reading those. So I've been trying to educate myself and being very, as I say, there's no pressure for them to try touch your taste. But it's just as you say, it's a continuing cycle of holding your breath. Will he, will he not? Okay, that food's gone from the list. Okay, what can we do next? So it's continuing. So I'm going to just shoot off to the next questions.
yes.
I realize we have so many. We may end up having to make this a part two, Teresa, if you have the
That's
time,
okay.
because
Yeah, of
I
course.
don't think we'll ever get through all the questions.
That's
Okay,
okay.
so I suppose this is a really important one because as you mentioned earlier, there's different types of kind of eating differences. And I
Yes.
suppose if we're looking this is the next heading, under the heading of diagnosing and understanding Arfid. So this is a really important question. I think if you're a parent listening, it's really important to listen. Hopefully you've listened to it all. Maybe not my pieces, but especially fantastic Teresa's, I suppose views on everything to do with Arfid. But I suppose this is a really important one so you really know what you're seeing as a parent. And that is, what are the key signs and symptoms of Arfid that parents or caregivers should look for?
So I suppose probably one of the biggest things is the children eat a restricted range of food. So they either eat a limited variety of food or a limited amount of food. And usually when I meet a child with ARFID, often the amount of food they eat will be in single digits. But prior to, and I always encourage parents to kind of keep their lens broad initially, and parents will come to me and they'll say, I think my child is ARFID and I don't know what to do. And I usually say to them, okay, let's just pause for a moment because actually there's plenty of other reasons as to why your child might be eating in a particular way. And there's several facets involved in pulling apart what's going on for that child. And ARFID as a diagnosis is only one of those pictures or pieces of the puzzle. So initially, I asked parents to think about whether their child falls into the category of being a picky eater or a problem eater. And if you go onto my website, thefeedingtherapist.co.uk, I have a questionnaire on there where parents can go in and they will literally see the difference between what we call a picky eater and a problem eater. So a picky eater is a child who might eat, maybe between 20 and 30 foods. And look, I'm not limiting the frustration or the difficulties of having. I have a picky eater myself, so I understand it is really hard. But there is still a vast difference between living with a child who's a picky eater versus living with a child who's a problem eater. So, problem eater then tends to be, as I said, could be less than 15 foods. The problem eating tends to get worse as time goes on. It tends to become more severe in nature. The duration, picky eating usually lasts about 2 or 3 years and it might start to subside after that. Problem eating will just continue to go on and on and on. The difficulties, definitely in terms of quality of life, that's a big thing. Occupational therapists love talking about quality of life. But one thing that I urge parents to think about is like, so my child who's a picky eater, he eats his range of foods and he loves them, but he can go to birthday parties and go to soft play, he can go on holidays and he just eats the food he likes, but he can go to all those places, no problem, and eat all those foods. In my clinical experience, with my clinical lens, children who are problem eaters or have complex feeding challenges, the impact on their overall quality of life is much greater. So oftentimes they cannot eat outside of the home, they cannot eat in restaurants, they cannot go to birthday parties because of the fear related to eating. So there's a much bigger picture to consider in terms of outside of ARFID specifically. There's other diagnoses to consider as well. So the other one that I talk to parents a lot about is a diagnosis called Paediatric Feeding Disorder, PFD. And PFD is slightly different to ARFID in that it relates to what we talk about, an impaired intake of oral food. So, and there's 4 different domains for that, but pediatric feeding disorder is actually deemed like a developmental condition, if you like. So that is diagnosed by a multidisciplinary team. So ideally, it would be like an occupational therapist, speech and language therapist, dietitian, maybe psychologist. So it tends to have more of like a medical lens or a medical origin. But you can have and I have met lots of autistic children who have pediatric feeding disorder, and pediatric feeding disorder is actually more common than ARFID right now.
Really?
Yes,
God,
and
that's interesting.
the amount of people who have heard of ARFID is very limited, but the amount of people who have heard of pediatric feeding disorder is even way, way, way less.
Yeah, I've
Or
never
parents,
heard of that, being honest, until you
yeah, I know
mentioned it
it's
to me.
fascinating. Yeah, and the amount of parents who will come to me and say, I think my child might have Arfid, and then they explain, the trajectory since the child was born and how the child's feeding has looked. Like, I go right back to the start with parents, literally from the baby was born, and talk to them about how they fed. And then I think to myself, hang on, I think this is more of a pediatric feeding disorder situation we have going on here than Arfid. But I will say I'm not the person to diagnose either of those conditions by myself. So if you're looking for a diagnosis, or if you suspect your child might have a diagnosis of Arfid, it's either a pediatrician, psychologist, or psychiatrist who makes that diagnosis, and nobody else. If it is a pediatric feeding disorder, then, as I said, it's usually a multidisciplinary team who make that diagnosis. The real struggle right now is that in Ireland, and not just in Ireland, in the UK and all around the world, to be honest, there's a real challenge in accessing services for these complex feeding presentations. And there's a couple of reasons for that. I suppose the first one is, as I said, both are really new presentation, new diagnosis in the literature. PFD is even newer than Arfid. And so it just takes time for the professionals to develop the skills and the training and the understanding. And there's still lots of medical professionals out there who are still learning about these conditions. And the unfortunate consequence of that is then that sometimes parents will go to a GP or a pediatrician or whoever it is, and they'll say, I'm really concerned my child's only eating 7 foods. I'm worried they're malnourished. And, they maybe don't get the response they were hoping for, or the understanding they were hoping for, or they might be told it's just picky eating, they're fine. And there is this myth that if the child's weight is stable, that they must be fine. And the reality is that you would be amazed at the nutrition that children can get from a very limited range or amount of food. So, I would have seen children in the complex feeding clinic who might have survived on like milk, Pom Bears, and plain crackers. And on paper, their nutrition would have been okay. But the reality was they were miserable in reality, because they were constantly fearful about eating. And fear and anxiety in relation to food and eating are a huge part of this picture. So, the children are maybe fearful of, as I said, like the sensory side of eating. So whether it's the smells are too strong, or the taste is too strong, or they don't want to be around other people when they're chewing noisily on their food, or whatever it is, or they can be anxious about possibly being made to eat things that they don't want to eat. That fear is, for me, a real defining characteristic of Arfid.
And do you know what's interesting about that? I was listening to you chat away. I didn't want to interrupt you, because even autistically,
Sorry.
I'm always like, no, but I'm like autistically going, okay, is it okay to interrupt? Okay, don't interrupt. And then I'm okay,
Absolutely.
wait till you feel like you can interrupt. But like when you were saying about the problem eating and how you nearly see it, it's like that kind of dwindling off of the capacity to eat, and how the food is nearly diminishing down to, as you say, single digit numbers. Or even
Yeah.
you were talking about like going into restaurants. I can give you 2 exact examples of Max. Last summer, again, I knew better, but I was like, sure, he might like it. We normally would only go through the drive-through again. We don't
Oh,
regularly
yeah.
spend our time at McDonald's, but it's something that he will eat. Is McDonald's? He calls them
Yeah.
chippies, and
Ah,
we usually would just go through the drive-through. And that particular day, I thought, it looks quite empty, and he has in the now maybe a few years ago would have gone in there, and I thought maybe we'll go
okay.
in and he might like it. But the minute we went in, I knew it was a bad idea, because somebody close by seemed to have been eating chicken nuggets and burgers, and again, he only eats beige, like beige, was it brown, beige type of food. And he immediately was like, it wasn't like he was angry, he was
Yeah.
terrified, and he wanted to
Oh,
go. And I remember leaving my husband there with the 2 older boys, and I said, listen, I'm going to bring Max out to the car, we'll continue to go, I'll go back into the car, we'll go around the drive through as he likes it, and then he's safe to eat his food away from all the other people. That was
yeah.
one mom mistake, as I said, I never made that mistake again. I understood that it was too much for him, but it wasn't too much for him that you've changed the plan, because it wasn't that particular piece. I could see him looking at everyone eating, and he was like, oh, and I was like, oh my God, why did I do this to him? I thought he might enjoy it, just to be like in the restaurant instead of always like
Oh, I
in the car.
know.
Whereas
Yeah.
separately from Max, I would bring the other boys in, and they'd enjoy that kind of thing.
Yeah.
That was one thing. And then the other thing that stood out to me was, many years ago, I might have brought Max into the likes of a supermarket, but as this has
Mm.
developed and progressively got, I suppose, I don't know what the right language is, more, it's taken more hold of the way that he can, tolerate food or being around food. I wouldn't dream now of like bringing him into the likes of a Tesco and having him choose food, because he would be terrified. He would just be
Wow.
like, why are you showing me oh, no, why are we doing this? So instead, I bring the food to him, like he'll see the shop. But he does like to do, which I think is a positive, is when I bring in the shopping, like in the bags from the store, like as if you're watching this on camera, I'm in like a tiny little cottage in the west of Ireland. When I come in, behind that yellow door, there's our front door, which is the side of the house, very strange. But when I come into shopping bags, he'll go, yes. And I'm like, this is good. And he goes through and he's up, but he always looks for, he can't say jammy dodger, so he calls them doggy cookies. So he'll be like, doggy
Oh,
cookies. And I always make sure I have loads of them, because I'm like, no,
oh,
it's no, not, I know they're not an apple or an orange, but if it's food and he's going to eat it, let's have it. And he'll hold them up and he'll be like, yes, dog cookies. And then I'm like, I
oh.
nearly feel like crying, because I'm like, I'd love to give you a big dinner, but I don't want to overwhelm you, so I won't do that to you. But yeah, it just reminding me of that. Like, there are two places I can't right now go with Max. It's like into a restaurant, and certainly not into like a supermarket to randomly pick at will any type of food at all. Like, he would be traumatized beyond belief.
And like that, I just think that describes so well the implications of living with somebody who has this diagnosis, that, I would bring my kids into the supermarket, but I wouldn't even think about it. Or, they'd be begging me to go to McDonald's. And a mum said to me recently, her child, he doesn't eat like dinners at all, ever really, any kind of meals. And so, if they occasionally, they might get a McDonald's chips. And I think recently, sadly, this mum had some opinions and judgment from somebody else, and kind of said,
Oh,
wow, like, there was some
terrible.
unnecessary opinions
Unkindness.
on this child being able to eat chips, like, very regularly. And as this mum said to me, she said, I would give my right arm for my child to be even able to eat
If
the
Max would
chicken
eat a
nuggets in
Christmas dinner,
McDonald's.
I swear, I
Oh,
booked the North Pole and thanks Santa personally.
I
I would be
know.
thrilled. But the reality is that on Christmas Day, I will be cooking Max, if I'm lucky, if he'll allow me, mashed potato with a lot, probably way more butter than should be ever given to anyone. But I'm like, if it's calories, I'm giving them, but he'll eat it.
Absolutely.
If
Yeah,
he'll eat the potatoes and he'll eat his, again, bachelor's beans, then that's what he's having for Christmas dinner, because at least I know he'll eat it.
exactly. And that will make him happier on Christmas Day than
Then load of,
if
well,
you put if you put a Christmas dinner in front of him and he
he'd
was completely
run,
overwhelmed and distressed, he'd probably just leave the table.
he'd be
So
bawling crying.
exactly. And I always say to parents, like, connection before food.
Yeah.
So sometimes, I might work with the family for 1 or 2 sessions, and then we'll regroup, and they'll say to me, well, like, they're not eating, but they are sitting at the table now for dinner time, and they can sit there and chat away while everyone else eats. And I just say, that is amazing. That is fantastic. And I would take that over them sitting there by themselves and eating whatever it is, because I just think it's so important to be able to come together and
And
have
create
that
that sense of
connection.
safety, that they know that they can
Absolutely.
trust you and you trust them to know what they can't tolerate right now.
100%. And the training I've done, so I work in an area, like, I suppose the approach that I take is called responsive feeding therapy. So it means that it's very kind of honoring the person's autonomy and respecting what they need in that moment. And the belief is that the child or the individual needs both emotional security, so trust and feeling safe, and sensory security. So knowing that those needs will be met at the table or wherever they choose to eat. And they can only eat when they have those things in place. So, for example, if a child goes to their grandparents' house and they suspect that granny might maybe plonk a dinner down in front of them, um, they probably just won't even go to the table,
Yeah.
because they don't trust the
Be too
situation.
scared.
Exactly. Yeah. And just too overwhelmed. But I just, one point that you were mentioning there, is kind of the concept that I call food neutrality. And, there's a lot of the time parents come to me, and I suppose guilt is an emotion that I hear so
Massive.
much from parents, and it breaks my heart, because I say to parents, you didn't cause this. Like, nobody has caused this. You definitely didn't cause it. So,
No.
um, I really do try to say to parents, like, please try and leave the guilt at the door as much as you can, because it breaks my heart. Parents will say to me, I haven't done enough, and I dropped the ball, and over
They'll
the
be like,
summer
no.
I let things slide, and I've only been giving them, bland carbohydrates. But, like, if that's what the child wants in that moment, then give them that. Because, like, recently a mum said to me, oh, all they'll have for lunch is like a brioche roll. And I said to this mum, yeah, but what's there more calories in? A brioche roll or fresh air? So,
Brioche
like,
roll,
when you think about it from that perspective, of course we want the child to eat the brioche roll, because that's still better than them not eating.
for sure.
Um, and in my clinic, with all the families and children I work with, like, all food is good food.
Yeah, there's no
And
like shaming of food choices.
oh,
As I say, he might call it now. They're not actually dog biscuits; they're jammy Dodger biscuits. But he loves his doggy cookies. Like even there, I saw his dad passing behind me. There's a glass door behind me. If you're listening to this in a podcast, I saw him coming in. I nearly sure I saw like a red box of doggy cookies just to have them as a just in case if you won't eat anything
yeah,
else. So at least he'll try them.
absolutely. And he will still get nourishment from those, and he'll get enjoyment from those. So it's very hard though when we all grew up like with different beliefs, and maybe the previous generation had different beliefs around food, and you had to clear everything that was on your plate, and you had to, sit at the table and have good manners and eat what was put in front of you. And that we were all told about the starving children in other parts of the world, and you had to eat your dinner. Look, and we all grew up with that messaging, and that's definitely something that I feel quite passionate about, is trying to help not just parents, but entire families, grandparents, aunts and uncles, teachers, other medical professionals, to try and tune into what the child needs, what their body needs at that moment, and respond accordingly to that.
And
And that's not to say, like, I challenge children all the time, and I challenge parents all the time, but any changes, particularly in relation to feeding, you'll remember this from the Magical Mealtimes course. I use the analogy of the starfish when I talk
mhm.
about making any changes to a child's feeding, because I think the starfish is like the slowest moving creature on earth, but he keeps going and he gets there in his own way. And I kind of talk about slow, safe, and consistent. So any changes that we're making to a child's feeding, so for example, and it has to be at a level that the child's comfortable with. So if all they can tolerate changing at the moment is maybe changing the shape that their toast is served in. And for, as you understand, for Max, that might be a huge thing.
That's a big
You
event.
know,
Yeah.
it might be too much for him to tolerate at the moment. But any changes that we impose on the child have to be both neuroaffirmative, they have to be through a trauma informed lens,
Mhm.
and they have to be so tiny and so minuscule that they're not going to overwhelm the child.
I'll often say to parents, it's like when we think about monotropic thinking of autistic people, it's like moving the dial for this. I always do this because I think of the lens. It's like moving the dial just a teeny tiny bit to get them
Yes.
to feel safe that there's a change occurring, but it's safe. We're going out. The change is good. It's going to help you, but we're doing it so slowly and checking in for, like, as I said, those high levels of anxiety to support that change. Like if you think of that monotropic thinking on the lens of Arfid as well, there's definitely a tie in there as well, where they have a very specific view of the world, and that very specific,
Yes.
it's not that polytropic broader view. It's that very, this is how food occurs for me in my life, and this is what I
Yes.
eat regarding food. But I'm going to jump into another question because
Okay.
we're very close to the finish time. Okay, I'm going to take one. Okay, I think you've covered like a lot, even just from what you've been saying
Okay, good.
there. Parents care. Okay, maybe this one, because this comes up a lot. I see it on social. How can parents and caregivers advocate for their autistic child with ARFID in school or other settings? Now, I have to say, we've been incredibly lucky. Our Max's teacher is like fully on board. I recommended your fabulous course to her as well. I know she felt it was fantastic. So I
Okay.
suppose, I know that's not always the case, and it's not that schools aren't doing their best. It's just they have a different view. So how would you support families to advocate in that arena?
I think, information is power, and at the same time, we want to kind of respect where everyone is coming from. So whether that's the teacher or uh, local GP or whoever it is, um, I think if you can arm yourself with some resources, so whether it's something like, directing the teacher to a website like my own, or in the UK, the Arfid awareness website is super. They have lots of lovely resources there. And they even have some resources that you can download on their website
Amazing.
for things like going to the GP. I think there's one maybe for schools as well. I think the more information you have, the better. And also, oftentimes parents will say to me, I've gone to the GP, but they didn't, it didn't really have the experience I was hoping for or whatever. And I do say to parents, if you're going looking for maybe advice or support or help or direction or guidance, it's often useful to maybe have documented some of your child's feeding challenges. So whether that's something like making a list of the amount of food your child eats, or how your child's eating has looked for the past 7 days, or if your child is more of a grazer and they don't really ever fill up at meal times, like to have some record of that, to be able to document to whether it's the school or the GP or pediatrician or whoever it is, I think it can be very useful to have those specifics ready to hand when you go
And
in.
even for the school, say if it's going to an external, so it's not, the school is not, we'd say, feeling challenged by this information, maybe having the school fill out that food diary as well. So you have that full day picture, day to day, of how the child is getting on. So that's great
Yeah,
advice. Okay, I'm going to look here now. We're at kind of the last few questions. I know there's so
great.
much more I could ask you, but what we might do is I might maybe put together maybe a blog post or something as well on Little Puddins, and link over to your own website if individuals would like more information from your incredible website. So, okay, I suppose here, are there books, tools, or resources you'd recommend? So I think you've kind of covered that maybe there. You've talked about the website, and maybe I could do that. Maybe that'll have that in the blog post. Do you think, Teresa? I could put down like Teresa's recommendations on books and then the website links. What do you think?
Yeah, that'd be great. There's one book that I love and I use it myself a lot, and you would have seen it
I think
recommended
I
in the
have it.
Magical Mealtime course. The food refusal book. It's Food Refusal and Avoidant Eating.
Yeah, I
It's
have
by
it
a
on my
lady.
bookshelf behind me. It's
Oh, it's
excellent.
brilliant. It is a fantastic book for parents and professionals. It's by a lady called Gillian Harris in the UK. She's kind of a powerhouse in the field of Arfid. There's another lady called Rachel Bryant Wall. I did some of her training courses in the UK. I think she's a psychologist or a psychiatrist in the UK. The Birmingham Food Refusal Service is great. My own website has lots of information. Just as we've said this already several times, just check where you're getting your information.
Mm-hmm.
I see social media and the information that comes in social media. It's kind of like, for me, it's the icing on the top. So if you have the credible information and then you feel like you'd like more support or,
Yeah.
community, social media is incredible for that. But just check your sources
But
first of
yeah,
all.
always go for that actual, because at the end of the day, for me, it's like, do I take the advice from a person on social media to help my son eat that may inadvertently, and not through the person's intention on social media or anybody else or my own, that my son might now drop another food, so say perhaps he's down now to 3 foods? Or do
I
I
know.
wait and I go to the clinician with the not only the lived experience of supporting families, but those years long clinical experience, and then also to those dedicated resources? And again, I might put together some kind of a blog post with links to everything you've recommended there, and again, link back to your own fantastic website. So it was the last question on my list. I know we're coming up to the hour. Is, what are your top tips for fostering a positive relationship with food for autistic individuals?
Okay, so the first one I would say is never let the child go hungry. Like, if that's the only information that someone was to take from today, I'd be happy with that. Try as much as you can to create like pressure-free meal times. And you would have learned more about this in the Magical Mealtimes course. We don't always realize that we're putting pressure on the
Yeah.
child to eat, and pressure can be positive or negative. So even just things like saying something like, I made this for you last week and you ate it then. Why can't you eat it now? That can be pressure. And even things like, if a child does eat, if you're like cheering them and
That would be
prompting
me.
them, but that can also be pressure. And I do that myself all the time. And, we all say, good girl, you cleared your plate. Well done, well done. But some children are innately people pleasers. And so then they want to please us, and then they'll feel the pressure to eat that way as well. So as much as you can, I just say to parents, just have like a poker face when it comes to eating. And if they want more, that's great. And if they don't, that's
That's like
okay
me
too.
feeding Max now. I'm just like, I'm in my internally, I'm sure I'm like, oh my God, please keep eating. But then I'm like, pretend I'm looking at my phone. He's looking at his iPad, and I just keep spooning,
Yeah.
going, this is great.
It's all chill. Yeah, you're trying to pretend, even if you're like not chilled inside, you're trying to pretend you're
Oh,
chilled in the
I'm
end.
like panicked, but I'm trying to
I
not appear
know,
panicked.
I know, I know. And even things like bribes,
Oh
reward
yeah.
charts. Again, parents think they are helping the child, but actually that can also intensify the pressure that the
And
child is
feelings of
eating.
shame and guilt as well on the child.
100%. And I don't know, I don't think I mentioned this already, but actually feeling anxious can actually suppress appetite.
Mm-hmm.
So not alone that it's unpleasant to feel anxious in relation to eating, but it actually has the additional impact that it can literally reduce your appetite and reduce your desire to eat. So as much as we can help the child to feel calm and regulated, and the course you would have learned all about kind of the role of sensory regulation and
Mm-hmm.
emotional regulation in relation to eating,
Co-regulation.
and the different kind of tools for that to help the child help their body feel calm and regulated when they do come to eat. And then I suppose no hiding foods. So, there's lots of recipes on social media for like hidden veg pasta sauces. And I have done it myself. I made that crucial error years ago. One day I was making pesto pasta for my boys, and I thought I followed a recipe and like disguised some cauliflower in it, and sure.
You'd know cauliflower a mile away
Yeah,
coming.
it was pretty well. It was like I ate it and it was lovely, but they were
What is it?
horrified.
Self-praise is like no praise. Is that, yeah.
And for ages then afterwards, they wouldn't eat the pesto pasta because they didn't trust that I hadn't. So no hiding anything in food, no disguising anything. If you are making any changes to the child's food, tell them. And it maybe even if your child is non-verbal or has, uses an AAC device or something like that, use whatever their preferred means of communication is to inform them of these changes, or even visuals, or even just something really simple like using a little whiteboard to draw what's going to
And making
happen.
sure that you have, say, in that AAC or even in, I know Max's school sent this home the other day. It's not related to food, but it was like even giving them the option to say, I don't want it or I don't like it. Because, sometimes we think, oh, well, if the person's not speaking, sure, they won't. Of course, they're a human being that have their own diverse way of communicating. Make sure you're providing those opportunities for them to say whatever they'd like to say. But in particular, no is very powerful as well, because it helps to abate that anxiety, but also that we respect that no as well.
100%. And the very last thing I will say is just in terms of eating and feeding and Arfid, like just meeting the individual where they're at. So if at the moment, if the only way that your child feels safe to eat is to sit on the sofa in front of the television eating like cheesy puffs from their favorite blue plate, you can still join them in that, and you can still create connection in that, because you could sit beside them and also eat cheesy puffs, also from a blue plate. And maybe tomorrow, then you could both eat the cheesy puffs from the same plate. So it is always possible to meet the child where they're at in that moment. And sometimes that's enough. We don't always have to change how the child is eating at that time. And sometimes being neuroaffirmative and honoring where they're at right now, that's enough for the child. And that's maybe all they can do at that moment.
Listen, Teresa, you have given me so much of your time and so much of your expertise, and I hope everyone has really enjoyed listening to all of, oh my gosh, so much of your insightful views and expertise on Arfid. Again, at the description part of this podcast, I'll have all the links that Teresa's recommended. In particular, I'll be recommending her own fantastic Magical Mealtimes program, and her website is jam-packed, and her social media as well. So I'll have it all there for everyone. So listen, thank you to everyone. A massive thank you to Teresa for taking the time. I know you're so busy.
Thanks,
for participating. And I suppose I will stop the podcast now and say, goodbye to you all until the next time. So thank you. Bye-bye.
Thank you. Bye.